Thank you. My name is Michael Dunham. I'm a faculty member at Louisiana State University's Health Science Center and the School of Medicine. I'm here on behalf of a group of LSU faculty that are developing a device called SafeMargin. This is for establishing tumor margins during a cancer surgery. The problem we're attempting to solve is that of positive tumor margins after cancer resection. When surgeons approach cancer surgically, they are attempting, of course, to remove the tumor completely. But this is a very significant problem. It varies between 20 to 40% of cases have positive margins at the end of surgery as measured on permanent histopathology of the surgical specimens. The net effect is a doubling of recurrence rates in the local regional field of the cancer, and survival rates overall are cut in half. The current standard for detecting tumor margins during cancer resection is frozen section analysis. This is basically where the surgeon takes samples either from the surgical bed or from the specimen and submits them for immediate evaluation by the pathologist. Basically, it's limited because of the number of sites that you can test. So there's a sampling error problem that really is the biggest issue. It's also expensive and it prolongs the surgical times significantly. Our solution is a simple handheld device that the surgeon uses to sample the surgical bed or the tumor specimen in real time in the operating room at the time of resection. And it's not limited to a few sites. It's essentially a method for continuous evaluation of the tumor margin, again, at the time of surgery. The device, the physics behind it is kind of complicated, but it's based on Raman scattering of laser light. Basically, if you shine a monochromatic light on a specimen, a small portion of it returns at a frequency different from the primary frequency. And this is a function of the, in our case, the tissue makeup, particularly proportions of nucleic acids and proteins. The our innovation is adapting this for surgical use in real time, and the other big innovation is the development of a AI-based classifier that can distinguish cancer from non-cancerous tissue in real time. We've been working on this for about 6 years, and we started out with murine studies. We studied immunocompromised mice implanted with human oropharyngeal cancer. And we had nearly perfect delineation of cancer from non-cancer tissues in the animal model as measured by histopathology. We've also completed tissue safety studies. There were potential issues with alterations of the tissue with the incident laser light that's used to elicit the spectrum. And using ex vivo tonsil specimens, we documented that there were no histologic changes related to the laser illumination at powers and durations useful for measuring the spectra in human tissues. And then we went on to ex vivo evaluation of some head and neck cancer surgical specimens. We've looked at larynx and oral cavity. Basically, these are studies where we've taken the device, looked at the spectral characterizations, the classification of cancer versus non-cancer in and around the margin, and compared it to permanent histopathological findings. And we overall have an accuracy in the mid-90s for both both larynx and oral cavity. The competitive landscape, there's a lot of active research in this area. There's a lot of funding the federal government is sponsoring to help reduce the incidence of cancer recurrence due to positive margins. We talked about frozen section analysis. Its issue is it's time-consuming, expensive, and inaccurate. There's also fluorescence-guided surgery. This is basically administration of a fluorescent probe that attaches to the tumor and can be illuminated under specific wavelengths to outline tumors intraoperatively. There's also anatomical image-guided surgery. This is basically in vivo microscopy, ultrasound, optical coherence tomography, and extensive, complicated areas. But basically, their drawback is they're complex, they're intrusive in the operating room, they're expensive, and both of these approaches in general have issues with sensitivity and specificity. Our device distinguishes itself in its simplicity. Basically, it's you hold it in your hand, you touch the device to the tissue, and it tells you whether or not you've got cancer or non-cancer, and you adjust your margins accordingly. It can be used in the tumor bed or on the tumor specimen after resection. This is an overview of the technological and commercialization development of this. It's a little bit of a busy slide, but basically this thing consists of three components. There's the base system that includes the spectrometer, the laser and Raman signal delivery. There's a handpiece that's disposable, that's designed specifically for use on tissue in the operating room. And then there's the software that goes along with the system to help that does the actual classification. And so this is a supervised machine learning model, and we've trained it for larynx and oral cavity, but in order to expand to other areas, including breast and colon and prostate, we basically have to go through the process of examining specimens and retraining the machine learning model. So in conclusion, outcomes in cancer resection with positive margins are awful. Very high levels of recurrence, regardless of the site, and reductions in survival significantly in patients that have positive margins after cancer resection. The current methods for obtaining clear margins are clearly inefficient and inaccurate. And our device offers surgeons a straightforward, efficient, and accurate method to delineate tumor margins during cancer surgery. I think I left enough time for a question.
What laser or what nanometer laser do you need?
785, near infrared. There are various lasers that are used for Raman spectroscopy. The issue that we initially had to overcome was autofluorescence. And by working with that wavelength and the various filters and computational methods, we were able to overcome that. That was part of developing this for use on human tissue. Thank you.